Okay, we're recording.
Okay, let's take it away. I'm Neil Maizlish, and I thought we'd just do very brief introduction so that everyone knows who else is on the phone. So just say what your organization, your name, your organization, and leave it at that. When we start with, let's see, we have a lot of folks from Air Resources Board. Why don't we start with those folks?
I'm Holly Jessup from the Air Resources Board, epidemiologist with the Research Division.
Welcome.
Hi, my name. Sorry, go ahead.
Hi, this is Maggie Witt. I'm with the Sustainable Transportation and Communities Division.
And hi, this is May Petratana. I'm with the Research Division at CARB.
Hi, everyone. I'm Aria. I'm with the Mobile Source Control Division at CARB.
Okay, great. Welcome.
And Leila Atella, Sustainable Transportation and Communities Division at CARB.
Great.
Good
Anyone
morning.
else?
This is Michael Harrison from Sustainable Transportation and Communities Division at CARB, Air Resources Engineer.
Wow, great. Big contingent from CARB. Great.
Hi, this is Feng Chao. Hi, Neil.
Hi.
Good to see you again. This is Feng Chao. I'm with the Research Division and CARB. Also, Neil, I have a question. Can you move your microphone close to you a little bit because your sound sounds a little bit far away from me. Thank you.
Okay. All right. Hopefully this will be better. Is that better?
Yes, thank you.
Okay. Okay. What about from CDPH?
This is, sorry.
Oh yeah,
Cynthia
of course, Cynthia.
from Research Division.
From CDPH? Do we, or, yeah.
Yeah, we have a bunch of people from CDPH. I'll start. This is Meredith Millette from the Climate Change and Health Equity Program. I'm an epidemiologist.
I guess I'll jump on next. Dan Wu, Health Program and Policy Specialist, also Climate Change and Health Equity Program, CDPH.
Hey, this is Orion Stewart. I'm a researcher at CDPH with the Crash Medical Outcomes Data Project in the Injury and Violence Prevention branch.
Great. Nice to meet you. Other folks from CDPH?
Hi, this is Marianne Hernandez. I work for the Active Transportation and Safety Program in the Injury and Violence Prevention branch at CDPH.
Welcome, great. Okay, other folks from CDPH? Okay, let's move on to other state agencies. We have folks from SGC on board.
Hi, I'm William Walker. I'm a transportation planner with SGC working on AB 285 implementation.
Okay, great. Welcome.
Thank you. Hi, everyone. Good morning.
Anyone else from SGC? What about OPR? Do we have folks from OPR on board?
Hi, everyone. Nikki Caravelli here, Assistant Planner at the Office of Planning and Research with the Climate Resilience Team.
Okay, welcome. Have I left out any other state agency folks? Or we have anyone from Caltrans or CTA? Anyone else who hasn't introduced themselves?
Hi, this is Elliot Wezerick. I work at the consultancy ICF, and I'm collaborating with Sac Metro Air Quality Management District on the CaliMod tool update. Pleased to join this. Got the invitation forwarded from me.
Okay, great. Welcome. So it's a pretty eclectic group of folks, including epidemiologists, transportation planners, environmental engineers, sustainable transportation folks. So it should be a really good gathering here for folks to get into the nitty-gritty of the model. So without further ado, I'm going to share my screen. Yeah. And you should have the slides as well, in case you want to follow along. There'll be opportunities in the course of the day to actually have hands-on with the model. What I'm going to do is go through the background, some of which you've already got, so I'll probably pass through that quickly. Introduction to the model itself, talk about the model inputs, the model outputs, the methodology in which there'll be an exercise in which you, in a Excel somewhat pencil paper version, are going to get a chance to actually do the calculations in a simplified format. My goal is to demystify the model. Many folks from different disciplines, when they hear about other people's models, they get the impression that it's a big black box and they really don't understand how things work. So I'm trying to demystify how ITHIM works and make it accessible. And as I point out to many folks, to do this successfully, you only need 8th grade algebra. So if you have kids and you've been helping them, you're probably in good shape now. I'll also talk about the strengths, limitations, the assumptions behind ITHIM. And then we're going to spend a bunch of time on the website itself, where you'll be able to collectively seek out the inputs or make changes to the scenarios, time periods, geographies, get outputs, and familiarize yourself where you would find the outputs. And then we'll have just a brief session for a question and answer. I think because the group is relatively small, that if you have brief questions, you don't have to save them up to the very end. We could deal with them sort of when they're occurring so that you don't lose them and that they'll be relevant for the discussion. So without further ado, there's going to be a 5-minute break scheduled in along the way, but if you have to, take a bio break, whatever, it's okay. Just leave and rejoin as you need. So we're all of you, and you can unmute at this stage. Meredith, if you want to unmute folks. Did everyone who's on board now see the intro?
I think people can unmute themselves, but let me know if that's not true.
Yeah.
Yes, I did. Holly Jessup.
Okay, let me put it this way. Is there anyone who didn't join at 9 o'clock to see the overview? I mean, it's okay to say you didn't, that's okay. All right, but it sounds like everyone at least says that they saw this. So I'm not going to go through the intro stuff over again. I'm going to start with the guts and really get into what the model does. So hopefully you've all had enough coffee this morning, because we're going to start right in with the guts of this. So the basic methodology for ITHIM is called comparative risk assessment. And for some of you, especially in the transportation arena, you may not have seen this or called this in a health context, but this kind of modeling is built into lots of engineering practice. Sometimes it's called failure rate or damage functions, and they're given all kinds of names that we don't use in epidemiology or public health, but the basic idea is not that different. So in order to do the model, you need 3 essential pieces of information. You need a burden of disease. And for the sake of just what that means now, I'll get into more detail of some of the more sophisticated ways of representing health status. But just think of it in terms of annual number of deaths. That's a way to characterize the disease burden of a society or a state. Then you need dose response functions. And they have a particular format where it's looking at the change in deaths per unit dose. So again, other fields call this different things. In transportation planning and urban planning, I think you guys call it elasticities, but in public health, we call it a dose response function. But it's basically the same idea that there's going to be a change in one quantity per unit of another. But what are those quantities? Those doses really are about the scenarios and the change in a dose. So we have some level at the baseline scenario travel pattern, and then one at the scenario, the alternative. And you can't see it, but my doggy 11-month-old golden retriever wants to play. So hopefully you won't be distracted, or I won't be distracted. Anyway, so you can see by just looking at the dose, so it's a delta dose through transportation, excuse me, you can't play with that thing. You can see that there's a change in dose. When you multiply it by the change in deaths per unit dose, the dose drops out and you just get 8% change times the number of deaths. So that will give you the change in the annual number of deaths. So there's a lot of mathematical additions to this, but this is the basic idea. Now, when we talk about pieces of this population attributable fraction is epidemiologic jargon that just says what % of the deaths would be prevented if you achieve the scenario level of the dose. So let me talk about what is the dose. It's travel-related physical activity from active transport. So we're talking about a certain population level of minutes per person, per week of physical activity, walking, bicycling in transportation. For air pollution, we have car emissions. So it's a change in the level of car emissions. And that is a function of car VMT and the emissions rate of the primary and secondary constituents of fine particulate matter. So again, these doses reflect those three pathways that I mentioned in the introduction. So we're talking about physical activity, road traffic injuries, and air pollution as being the three main health impact pathways that are modeled in ITHIM. The third level of dose is miles traveled at risk of a collision by walking, cycling, riding in cars, motorcycles, buses, and trucks. You can almost consider it in a sort of a crass kind of way as a crash derby. You have all these modes are interacting, and on occasion they collide with one another. So that is what the dose is. So physical activity, it's minutes of bicycling and walking. Air pollution, it's really VMT changes that are driving emissions amounts that are going out the tailpipes. And then the risk of collision is purely driven by the distances that are traveled to the collision by both the victim as well as the striking vehicle. So let me now go into some of the more detailed pieces of this. For physical activity, I mentioned it's about time. So we have a baseline per capita mean active travel time. And this would be minutes per week, and its standard deviation. And it's broken down by age and sex. The source of the information is the California Household Travel Survey. So it turns out, again, this is probably buried in your algebra from years ago, but if you have the mean and standard deviation of a population, you can predict what the entire distribution is if you make some assumptions about what the underlying distribution is. So we know that active transportation follows a log normal distribution. So here's the minutes per day of active travel. Here's the population percentage. And this is a somewhat idealized curve, but it's pretty close to what is experienced and what we see in travel survey data. There's a large percentage of people who do very little, close to zero. And then there is a long tail of some people who do a lot of biking and walking in the transportation system. Now, what the ITHIM model actually does is it doesn't look at every point along the distribution. It actually looks at quintiles of the distribution. So that is what the change in travel patterns does. We're actually talking about an alteration in the distribution of active travel times across the entire range of travel times. So if you can imagine increased physical activity, you can imagine a right shifting of these quintiles to the right as we increase active travel. And that is precisely what the model is doing. Now, in addition to the physical activity, the intensity of that physical activity is really important, because the epidemiologic literature on physical activity isn't just about minutes, it's about minutes weighted by their intensity. So there are standardized weights of physical activity, and given age and sex breakdowns, given speeds of walking and cycling. So many transportation models use 3 miles an hour for walking and 12 miles an hour for cycling. But we vary that up and down a little bit based on age and gender. And this comes from a data source where people are actually put in a laboratory setting on exercise ergometers, and they walk up inclines, they walk at different rates. They look at the oxygen consumption rates of people, so they know what the caloric output is. So many of the dose response curves for physical activity are expressed in terms of what's called METs. It's a metabolic equivalent task. And that is just a way to express that basically at rest, your very basal level is assigned the level of 1 MET. If you are just sitting in a chair like I am doing now, maybe 2 METs. Once you're up and walking, you're getting now 3 METs. So the idea that you would weight the time you spend in physical activity with its intensity level. So bicycling is more intense than walking. So it has a higher MET capability. So this is what's actually being modeled, is the energetic equivalent dose. That's what is under the hood of ITHIM. When it comes to the other inputs, we're really talking about distance as being what is driving the model. So the baseline and scenario per capita mean annual distances, and it's broken down by modes. You have walk, bicycle, car, both the driver and passengers, motorcycle, bus, truck, and rail. And most of the data sources here are coming from the California Household Travel Survey. The truck isn't. That's coming from the statewide travel demand model, or regional MPO data on truck travel. That's one of the big challenges of calibrating the model. We also look at road traffic injuries by the facility type. Now, facility type for the transportation folks, they know what that means, but for the health-oriented people, facility type can be really, what is the roadway type? Is it a local road? Is it an arterial? Is it a highway? These are, in essence, surrogates for speed and volume. And we also know that the substitution that we're talking about between bicycling, walking, and cars is largely happening on local and arterials. So we don't expect to have massive amounts of cyclists or pedestrians on highways. So we have to break down the vehicle miles traveled by facility type so that we can make the injuries appropriate when we do the substitution to just local roads and our arterials. Otherwise, we would be attributing highway car mile reduction with injuries with cyclists and pedestrians, which just don't happen. So it's important to be able to do that. And again, the MPOs and the statewide travel demand model are that. For the air pollution, tons per day of car emissions, again, that's driven by VMT of cars. And we're looking at PM 2.5, we're looking at NOx, and tire and brake wear are the precursors to the PM 2.5 in transportation. For the amount of carbon reduction, we're looking at the amount of CO2 per mile, per car mile traveled. And again, that's VMT weighted by the fuel source, so that we have an appropriate estimate, especially as market share for electric vehicles increases over time. And again, MFAC 2017, that's a CARB air pollution modeling product for mobile sources that we use for that. I want to talk a little bit about the built-in scenarios. Let me just stop before I go on. Are there any questions at this point? Are people following pretty much okay? Could someone not mute themselves and speak up? Okay, I see a couple of signs. Okay, I just want to make sure that people
You're not talking to the void.
Yeah, right, that people are with me. Okay, cool. All right. So I think we have a few people who may have entered since the start. I just see Victoria Custodio from CDPH just joined us, so welcome. And I'm going to talk about some of the built-in scenarios. Again, I mentioned these in the introduction. I'll go through this quickly. And if you have any questions, let me know. Again, what's built in is the two main state agency goals, one through the carbon reduction viewpoint, the other is really through a sustainable mobility. And what it is, they're all multiples of a baseline level. And that baseline is established from 2010 data or 2011-12 data from the California Household Travel Survey. So we see a quadrupling of walking and transit, as well as a 9-fold increase in cycling in the CARB scoping plan. So that's the 2017 document that, again, this is an aspirational goal that to achieve this by the year 2030. Caltrans Strategic Management Plan, which predated the CARB scoping plan, has a more modest level of increase, a doubling of walking and transit and a tripling of cycling. But that is supposed to have been achieved by this year, by the end of this year. So again, these are just ways to re-express multiples of the baseline. We have the national health goals, and again, this comes from the US Surgeon General's longstanding recommendations that are focused on adult behavior, that an optimum level of health will be achieved through 150 minutes a week of moderate or vigorous physical activity. I'll show you a dose response curve in a little bit where that's coming from. Then we have the regional transportation plan updates. So I went through the EIRs of the large MPOs. So these include MTC, SACOG, SANDAG, SCAG, and for the San Joaquin Valley, I primarily based it on Fresno COG's data, but expanded to the population of the entire San Joaquin Valley. So we have those EIRs. In them, they provide estimates of the increase in or changes in walking, cycling, car travel. So I was able to use those data, which are public, to construct what that means in terms of ITHIM inputs. Then there's all these what if scenarios, again, multiples of the baseline for walking, transit, and cycling. But in this one, you're allowed to not make the assumption, by default, it makes the assumptions that all the miles increased by walking and cycling are offset by decreases in car travel. So in this particular iteration, you're allowed for leakage, where you don't have a one-to-one mile substitution. And in our work for SB 347, I think it was Chris Ganson who really wanted to see what this might look like if in fact we couldn't achieve that mode forcing substitution. It was also acknowledged that you can have over substitution too. You can have certain configurations of the built environment where instead of going out to the big box store in the suburbs, you get your retail much more locally, and you are actually driving with a car with a bicycle or walking, far less than you would with cars. So at any rate, we have that option there. Then the fixed amount of minutes per week for walking and cycling. And this is really interesting. So you can see there may be a total amount of physical activity, but if you want to vary the proportions between walking and cycling, you can see what the relative health benefits of walking versus cycling are in a really graphic way. Then the replacing half of short car trips is another kind of what if scenario. We recognize that we're not going to replace all of them. You can't be bringing home refrigerators on your back or in your saddlebags, but a substantial number of trips that are less than 5 miles could be substituted given a built environment where you'd have a lot of retail or other destinations that were in your 20-minute neighborhood. And low carbon driving is really comes from Nick Lutzy's work at UC Davis, where he basically made projections of what he thought the market might look like if there was a rapid adoption of hybrid, electrified, fuel cell, the works in the transportation sector by 2045. And this would result in a 33% reduction from the 2000 level. You can actually alter some of the parameters in the model that you can accelerate this if you'd like. But we can talk about that. If you'd like to see other kinds of low carbon driving assumptions, like to say what would be the rate of increase of electrification that would achieve carbon neutrality by 2045. It's probably about 2% per year that would do that. But if you wanted to program that, you'd be able to do that. All right, let me switch over now to the inputs on health and the burden of disease. And there's primarily 2 inputs. One is deaths. Now, I don't think we need to explain much about that, but disability adjusted life years. And again, these are broken down by age and sex, race, income, and cause of death and illness. And I will give a little bit more explanation of what a disability adjusted life year is in a minute for those who find that as a new novel concept. The data sources are from the Institute for Health Metrics and CDPH. And the Institute for Health Metrics, I think folks may have heard because their COVID modeling is being used by the White House and other groups. So they are part of the University of Washington School of Public Health, and they have Christopher Murray there, who's been involved in the Global Burden of Disease Project, which is an international WHO, World Health Organization project for decades now. CDPH data are used to fine tune it to make these projections that are at the state level relevant for counties, because we know that the county death rates vary substantially. They're much higher in the valley and elsewhere, so we need to take into account a local variation in the burden of disease. So that's where CDPH data comes in important. Population projections in 5-year increments. Those are broken down by age, sex, race, and ethnicity, and for income only for the year 2010. But for these other variables, they're broken down through 2050. And that largely comes from the California Department of Finance, through their demographics unit. With projecting the change in the population, we also have to acknowledge that the burden of disease is going to change over time as well. Despite a lot of the doom and gloom for chronic diseases, the rates of death are actually going down slightly when you break it down by age and sex groups. It's probably public health measures as well as improved medical care, which is making this happen. But we also have to acknowledge that the population is getting older. I mean, it's really shifting to the older age groups. So you have sort of 2 offsetting phenomenon going on here. The age and sex specific death rates are actually going down a little bit, but a greater proportion of the population is in these older groups. So it's not contradictory to have an increase in the burden of disease, despite the fact that in age and sex strata, things are improving. Anyway, the purveyors of these projections is the Social Security Administration, which of course has to be able to project what the mortality rates are of people who are receiving Social Security benefits, because they have to have enough money to pay the beneficiaries. And the longer they live, the more benefits they pay. So they pay attention to these death rates quite closely. Traffic collisions comes from our California Highway Patrol through the SWITRs, the statewide integrated traffic reporting system. And that is through every traffic collision that is investigated by local or state enforcement personnel, record the results on the 555 form, and those are key entered. And SafeTrek at UC Berkeley actually geocodes those, so we're able to know the location of each of the collisions, and we focus on severe and fatal, not the property only or the non-property collisions. So this is because that's where the morbidity and mortality is. Very minor injuries don't really contribute much to deaths or to disability adjusted life years. So, but we need to be able to stratify the injuries by their location, meaning local road, arterial, or highway, because that's part of what comes next, which is how we look at injuries. And this is probably going to be novel for most people. This is a big challenge in epidemiology, to express risk-based measures of injury when it comes to traffic or motor vehicle injuries. Many times it's expressed on a population basis, and it doesn't really take into account the distances or the time at risk of travel. So this is a novel approach, looking at a matrix of looking at sort of the two to tango. And if you're gonna have a collision, you need two or more parties to get together to occupy the same space at the same time. So what we have here is a pairwise matrix of the different modes and how they collide with one another. So you have bike with bike, and bike with pedestrian, and bike with motorcycle, and all the different combinations. The way we express this is we look at the striking vehicle, and the distance that it traveled is really the vehicle miles traveled. For the victim, which includes the occupants of motor vehicles, that's the person miles traveled, or personal miles traveled. So for some of you, this idea of a VMT, which sounds familiar, but there's another dimension to this, which is occupancy or occupants, or PMT. So PMT is related to VMT via occupancy. So if you have one car that drives 1 mile, that's 1 mile of VMT. But if it has a driver and a passenger, collectively, they contribute 2 person miles. So when you divide 2 over the 1 VMT, you get occupancy. So you'll see in one of the upcoming examples where we'll make distinctions between PMT and VMT for risk of fatal and serious injuries. As I mentioned before, we stratify the injury risk. So this matrix repeats itself actually 6 times. 3 times for fatal, for arterial, local, and highway, and 3 times for serious, arterial, local, and highway. So it becomes quite ponderous, and that's why we have this as a computer program rather than as a spreadsheet or something you do manually. All right, I'm now going to shift gears and talk about the dose response functions that I mentioned earlier. There's a physical activity dose response functions and road traffic injury dose response functions. For the physical activity, we're specifically talking about diagnostic entities. So it's not generically all diseases are related to physical activity. We're choosing the ones that are high prevalence and ones that have a high degree of evidence. And a lot of the evidence is coming from randomized controlled trials as well as observational studies. So these, if you recall the percent change in deaths per unit dose, we're really talking about per met hour per week of dose of physical activity that are related to these specific diseases. So in this lower left-hand corner, you can see what this dose response curve actually looks like. On the bottom, it says leisure physical activity in met hours per week, but it's any kind of physical activity. Here is the hazard ratio, which is another measure of the relative risk of dying due to a particular cause. In this case, I'm using all causes, but it illustrates this very steep and nonlinear decrease with increasing physical activity or of a standardized intensity. So it's not an infinite amount of benefit, but it begins to level off quite quickly, but you have this very steep part. Unfortunately, most of our population is in the part that would have great benefit by even small increments of med hours per week of physical activity. So this is representative of a family of dose response curves, one for each one of these different disease entities. And they are stored in the ITHIM model, and we'll go through some of that a little bit later. For the road traffic injuries, this is one of the more famous studies that Peter Jacobson was involved in years ago. He's still around in Sacramento. I've spoken to him fairly recently, but this is another kind of dose response curve that's not linear, but this is the journey to work, and this is the relative risk of injury. And you can see this is also bicycling and cycling. When you're bicycling and walking, you can see the different, they follow this non-linear, really, it's almost like a square root function. With increasing levels of mode share, you get this sort of decrease in the relative risk. This has been called safety in numbers as well. So the model takes into account that the injury risk is really dependent on sort of the increase in mode share. For PM 2.5, which includes the cardiopulmonary diseases, we have studies that are done by the Health Effects Institute that have been poured over by Air Resources Board to come up with what the coefficient is for the change in disease risk per microgram per cubic meter of PM 2.5. That in turn has been translated into what they call incidence per ton. So how the disease rate changes per ton per day of the primary constituents of PM 2.5. So it actually relates how emissions impacts air levels, which in turn change the disease rate for PM 2.5. So again, ITHIM model uses what ARB uses for their regulatory work. I want to quickly go to our monetized outputs for health outcomes. Value of statistical life is 9.8 million in 2010. That comes from the US CPA. We also have national cost of illness estimates for those same specific diseases that were mentioned in the previous slide. And that largely comes from medical societies that are using the Medical Expenditure Panel Survey. So that is a national probability sample of doctors' offices and hospitals and other things where they literally count up all the medical bills for therapeutics and diagnostics. And they also go into out-of-pocket costs and monetize home care given by family members and things like that. So we have for each one, we can express that as a per capita amount and then multiply by some other factors. Now, I mentioned that the disability adjusted life years is going to be a somewhat unfamiliar concept. So I am going to just go quickly through what a disability adjusted life year is. And it really has two components. One is shortening of life expectancy, and the other is the degree of disability. So here, if someone, here's a woman who developed chronic low back pain at age 25, she dies prematurely at age 60. So this time period in which she is experiencing her low back pain has to count for something. So those years in which she's experiencing that have to be included with the fact that she died 22 and a half years before her life expectancy. She died at 60, but her life expectancy was 82.5. So there's 22.5 years that she did not achieve. So what this red area represents is the combination of premature mortality, which is at 22.5, and this period of time in which she's living with disability. But you can see it doesn't occupy the entire vertical component. So in other words, the degree of disability is also on a scale where 0 is no disability and 1 means death. The weight that different medical conditions get in this scheme is standardized and has actually been created by the World Health Organization in conjunction with clinicians and disability rights groups. So there is a sense of participation of the affected parties and how these weights are derived. And there's a compendium of weights that are used. So for right now, just you'll have to accept that these weights are meaningful and valid and are a way to incorporate the period of time that someone, or actually the population, is experiencing a chronic disease that is impairing their ability to function in some way. So that gets added in. So here we have the 35-year period in which the woman was experiencing low back pain, and the weight for this chronic low back pain is 0.37. That gets added to the 22 and a half years that she died prematurely, and the weight there is 1 because it's death. When you add this up, the experience of this one person is having 35.5 disability adjusted life years lost. Now, when we multiply this by entire populations, you get huge numbers. So here for California in 2010, there were 212,000 deaths. But when you look at the years of life lost, which was just this part of the curve, you get a rather large 3.6 million years of life lost. The disability component is also quite large. It's 3 million as well. And for a total of 6.7 million disability adjusted life years. What's also important about this is if you only focus on deaths, you're largely focusing on what's happening in the older part of the population. Many of the disability adjusted life years are actually occurring in the middle ages. And for some conditions like depression, they are very substantial, and there will be virtually no registering of deaths due to major depression. So what's really important about the disability adjusted life years, it's a complementary health outcome, so you can contextualize what the overall burden of disease is, not just what's happening largely in the older age groups. And just again to point out that the conditions in which we examine closely in ITHIM are not all medical conditions, but they are high prevalence ones. So heart disease, ischemic heart disease, inflammatory heart disease are included in this heart disease category. Not all cancers, but breast cancer and lung cancer and colon cancer are included. Stroke is included. Dementia, Alzheimer's disease, which is a major chronic respiratory diseases are included, especially with the PM 2.5. Unintentional injury, not the entire category, but the part that's related to motor traffic, motor vehicle injuries is included, diabetes. So again, just to reinforce that by working on ITHIM, you're actually working on some of the major causes of death and disability in California. So I'm looking at the clock and it's roughly 10:30 and we're doing good. Okay. Because the exercises are not going to come up for another few minutes. So if you want to bear with me, I'm going to go through the simplified version of this, and then we're going to go into breakout groups. And at that point, if you need to take a bio break or something, you can incorporate that into your breakout group. But this is, I think, at this point, we'll catch up, and it'll give you an opportunity to, rather than sit back and listen to me, you can actually do the ITHIM model in a very simplified way. And I've provided, hopefully everyone has an Excel spreadsheet that will help you with the calculation so it doesn't have to be impromptu really on paper and pencil.
Yeah, I did post that in the chat also, in addition to sending it around. And just let me know if you want me to tell you when it's any particular time, or it sounds like
I have a schedule to the left of me, so I'm consulting it, and we're going to be fine, folks. So what I'm going to do is now give an example of the comparative risk assessment. We're going to do a scenario. We're going to do double walking and triple cycling, and somewhat akin to the California Caltrans Strategic Management Plan. And I'm only going to do one disease per pathway. So again, we have 3 pathways. Everyone should shout this out: physical activity, road traffic injuries, and PM 2.5. Those are our 3. So I'm only going to do one disease. As you saw earlier, there's actually a cluster of diseases that are associated with PM 2.5 and physical activity. But to simplify things, we're just going to pick one disease for each one of those pathways. Road traffic injuries is road traffic injuries. Okay, we're just going to look at 3 modes. We're just going to look at walking, cycling, and cars. And I'll talk a little bit more about that. I'm not including motorcycles and trucks and rail and bus and all that stuff, but that's okay. Just for this example, it should be fine. We're not going to break this down by age and gender or the other covariates like race and ethnicity. We could, but it will complicate it immeasurably. So I'm trying to keep this simple so that you have some flavor of what it's doing. So this will not be a black box to you. And as you recall, and I'll go back to this slide because it's really important, is this slide, this distribution of physical activity. The actual model breaks it down, takes this theoretical distribution and quintilizes it. So it takes it into 5 different categories. We're not going to do 5 categories. We're just going to pick the median. That's going to be a simple measure of central tendency, and we're going to characterize the entire distribution by its median, which is far more representative than taking the mean, because in these kinds of log normal distributions, you just have a few points out here in the high levels of physical activity. They drag up the mean in a very unrepresentative way. So we're just going to take the median. So that's how we're going to characterize the distribution and the shift in the distribution of physical activity by looking at the median. So here's the basic scenario layout. We have the baseline, and then we have the scenario. And what I've done is converted the miles onto an annual basis per capita. And that includes people who don't travel by that mode too. So it's now a whole population distribution. So here we have in the baseline, the per capita. So it's per capita mean level of walking is 100 miles per person per year. In the scenario, we're going to double that. We're going up to 200 miles per person per year. For bicycling, again, we're tripling that. So we're from the baseline of 50 miles per person per year, we're going up to 150 miles. Now for the car total, now that's where we get into these concepts of PMT and VMT. If we're just looking at the car itself moving, assuming it's got a driver and it's not autonomous, that the car driver and VMT are synonymous. But once you add in the passengers, the total of that is personal miles traveled. Okay, so I just want to point that out where these are coming from. This is especially important when we look at the injury module of ITHIM. We need to make this distinction between PMT and VMT. For the other modes, walking and cycling, the PMT and the VMT are assumed to be the same thing. I mean, we're not talking about people walking with other people on their shoulders or bicycling with people on the handlebars and in the back. I mean, that does happen, but we're, again, simplifying it and basically saying the VMT and the PMT are going to be the same measure. So in these two scenarios, I mean, in the baseline and alternative, the total miles traveled is 1,150. And the way the miles were distributed in the alternative is that for every mile increase in active travel, there was a mile decrease in car travel, but it was done in a way that the occupancy was maintained the same in baseline and scenario. That way you don't have weird situations where all the drivers go do active travel, stranding the passengers in the back seat with no way of getting around. So this way it's more logical that as people are shifting, the occupants are shifting at the same rate as everyone else is as well. Now the percent reduction in VMT is going to be very important when we come to looking at the PM 2.5. Again, it's car miles traveled generates emissions. Emissions affect the ambient air quality, and that's what we need to ultimately model what people are breathing. But in order to get there, we need to know how much the VMT of cars has changed. So that's, and again, it's just simply baseline level, which is the 6,500 minus 6,370 divided by 6,500. That's just the percent change. There's no magic to that kind of calculation. It's just how we express percent change. Now, for the weekly median per capita active travel time, we have this broken down by walking and cycling. And the baseline, it turns out to be 20 minutes, per person per week. And we're doubling that in our scenario to be 40 minutes. And again, that's the median of the distribution. For bicycling, it's a threefold increase because that's what our scenario is about. We go from a median of 2 minutes per person per week to 6 minutes per person per week. So now let's go through the calculations. And this is where I've hopefully have done this in a way that minimizes the amount of calculations that you'll have to do. But let's start off here. Again, we need three things. We need a burden, we need a dose response function, and a change in the dose. And that will be used to predict what the output is. So I rearranged the order of these things. So here's the burden, here's the dose response function, and the change in physical activity. So let's do that first. Let's look at the change in physical activity. If you recall from the earlier slides, this is a intensity weighted amount of time. So it turns out that there's in that compendium of physical activity, there is a particular rating for walking, and it's 3.75 METs. That's the metabolic addition. So again, 1 MET is just being quiet and still no physical activity, but you're awake. 3 METs, 3.75 METs is you are walking. Okay, so we have 20 minutes of that. And I just want to point out that this is in minutes per week, but it gets re-expressed in MET hours per week. And the reason why is that all the epidemiologic studies that have done the dose response relationships use met hours per week rather than met minutes per week. So just remember, you have to divide by 60 to get there. So you multiply the 20 minutes per person per day by the per week by the 3.75, divide that by 60, and what the met hours per week is 1.25. That's what you get at baseline level. Now, when you double that, you should get double the METs, and that's exactly what you see here. For bicycling, it's 2 minutes times 6 METs, so that's the rating. So you can see how much more energetic, how many more calories you're expending per minute by cycling rather than walking. But that's a smaller baseline level to start with, but when you divide it by 60 to get it in net hours per week, it's 0.2. So the collective amount of physical activity at baseline is 1.45 METs. The corresponding amount at the scenario is 3.1 METs. The difference is what we are interested in. That's the change in dose. So let's put that aside for now. So we know that that's going to be the change in dose. Our dose response function has different parts, but here is, instead of using the percent symbol, I'm using what's called the relative risk. And that's just the rate of disease in the scenario group over the rate of disease in the baseline group. So it's just another way to express percent. 1 minus that, so if the relative risk is 1.5, the percent increase is 1 minus that, so it'd be 0.5 or 50%. So it's just algebra to re-express it. You can see how it's expressing this risk in terms of met hours per week. So this is our dose, and this baseline level is what the risk is for 1 unit of dose. That is taken to in this case, the square root power of the dose. And that again reflects what these curves look like. This is not a linear curve. This risk changes basically with the square root of the amount of METs. So that's why it looks like that. So when we, and the last piece is the burden. So this is now looking at ischemic heart disease. So as I mentioned before, we're only looking at one disease entity per pathway. So in this case, it's ischemic heart disease. It's popularly known as heart attacks, but it's really a collection of coronary heart disease and other kinds of conditions. And what we have is this constant 0.9383 is specific for that disease. And that's how the risk changes. So in other words, for every increase in MET, you get roughly a 7% reduction. Can you see that? 0.93 is roughly 0.7% reduction in risk. We take the 1.65, we take the square root of that because that's the shape of this dose response curve. So what this population attributable fraction is, which is multiplying the dose by the dose response, is 0.075. Pardon me, 0.0785. So in other words, at this increase in physical activity, there's roughly a 7% reduction in morbidity and mortality. So I'm going to multiply this population attributable fraction by the disease burden. So in California for 2010, there were 38,707 ischemic heart disease deaths. When you multiply that through, the change in the number of deaths per year is going to be 3,039 due to this shift from 20 to 40 minutes of median physical activity time. We repeat the same population attributable fraction for daily. So this is now looking at years of life lost as well as disability years living with disability. And you can see there's a rather large number of years of life lost. And again, that are gained. We are now avoiding deaths. We are avoiding loss of years of life and disability. So these represents improvements. So that's good. So that's where this is coming from. So this is part one, only one pathway. Now let's do the PM 2.5. So here, we're going to have to calculate what the dose is in terms of the change in the ambient levels of PM 2.5 due to a shift in CARB-VMT. It turns out that working with CARB staff, we have had a way of expressing the tons per day of emissions in terms of how many vehicle miles for cars that represents, and equilibrating that with what the mortality ratio is. So this is the coefficient that translates this 2% reduction in CARB-VMT into the change in PM2 levels that would be in the airshed of the region. We're doing all of California in this example. So all we do is multiply this 2% by this coefficient. And I should just point out, in this example, in the example that you'll be doing, don't convert it to 0.02. No, leave it as a percent. It's 2% times this fraction will give you this level of change in dose. So this dose is really small. It's like, less than a microgram. It's like a nanogram. So it's a very small change. When we look at the dose response relationship, it's not, it has a functional form that's similar. You have the relative risk per microgram per cubic meter of PM 2.5. But in this case, it's just the dose to the exponent. For those of you who find this a little bit odd, because you're more used to seeing 1 minus e to the beta x power, this is a mathematical equivalent, because when you take e to the beta, you are actually getting these kinds of values here. So anyway, if you want to prove it to yourself mathematically that they're the same, but I did this because some people are a little bit freaked out by seeing something to the e, to the exponent, to the e base, or natural logarithms, where they know 2 to the 3rd power, equals 8, or where it's a little bit more familiar. So again, it's a concession for algebra, but it's mathematically equivalent to everything you've probably seen before about how these dose response functions work. So when we actually use the values that are here, so for ischemic heart disease, the value, so for every increase in microgram per cubic meter of PM 2.5, you get about a 1% increase. That's what this base level represents. It's per 1 microgram per cubic meter. But now the dose is in terms of change in PM 2.5. When we do the math, we get a very small change in the population attributable fraction. It's 0.4022. Nonetheless, we multiply that by the burden of disease to get the number of deaths in dailies. So again, we're using ischemic heart disease here, and it is the burden of disease multiplied by the population attributable fraction. In this case, it's a fraction of 1 death. It's 0.86 deaths. For dailies, when we multiply it through, it's 12 dailies. So it's a rather small number. Nonetheless, it's how the calculation is done. So in the context of ITHIM, deaths are avoided if this population attributable fraction, so 1 minus the dose response function times dose, if it's greater than 0, well, then we have deaths are avoided. But if it's less than 0, so 1 minus something that is going to be greater than 0, that means deaths are increased. And the reason why I bring that up is because in this example, we're going to see an increase in the number of deaths due to road traffic injuries. So this is our last pathway and the last piece of this before you do the exercise yourself. So here, this is the most intensive as far as the algebra. And again, the risk is completely determined by the amount of travel for the striking vehicle and the victim. In other words, the way the PMT and the VMT change from baseline to scenario. So here I've created a little part of that complicated pairwise matrix, where here is the fatal injuries at baseline. And this is collision between pedestrian and a car, bike and a car, and cars and cars. And I should just point out that in California, these three cells represent about 50% of all fatal injuries in California. So they're not trivial. These are actually the major sources of morbidity and mortality in the transportation landscape. So the PMT applies to both, all the different modes. So again, in the baseline, we had 100 miles per year traveling by walking. The striking vehicle, again, that's VMT, that's 6,500 from the, so if we want to go back to the scenario, the 6,500, that's the VMT, and this is the baseline level. So we have the PMT of the victim times the VMT of the striking vehicle. And this reproduces for the scenario as well. We've doubled the amount of walking of the victim, and the striking has gone down because remember, we're offsetting some of the miles traveled by car by increases in walking and cycling. So this is the VMT in the scenario. And you can see the VMT in the scenario is always the same thing because we're talking about cars striking these other modes of travel. So we'll give you this basic layout so you can see where the PMT and the VMT is. Now we have the risk equation is a little bit more complicated, but let me just break it down by saying that the relative risk, and again, by mode, striking mode and victim mode. So we have I for victim, J for striking vehicle. You can see how it plays out. So the PMT of the scenario, the striking vehicle, pardon me, the victim times the VMT of the striking is in the numerator. The PMT for the baseline, the PMT of the victim times the VMT of the striking vehicle. And you take the square root of that, and that represents the change in risk. So it's really all about miles traveled, okay? And the square root of that reflects this curve. Where do I have the dose response? It reflects that it's not a simple linear relationship, that in fact, with increased levels of mode share, you actually get a deflection there. So when you go through all the different combinations, you get what the relative risk is for the three cells that we're doing. So for walking, the relative risk increases by 40%, 1.5. For bicycling, it goes up 1.7. But car to car actually goes down a little bit because again, we've removed car miles from the PMT in the scenario. So what we have to do now is go through these three cells and essentially weight them by the number of initial injuries. What we're aiming for is injuries in the scenario over injuries in the baseline, over all the different cells in that matrix. And 1 minus that is the expression of population attributable fraction. So when you multiply the 649 injuries, that's the fatal injuries in baseline, times the risk, you're essentially saying the scenario has 1.4 more injuries due to walk car collisions than the baseline, because again, the numerator is injuries in the scenario over injuries in the baseline. I know this is a little bit complicated to get your head around maybe the first time, but this is how the calculation works. So in the model, with a change in PMT and VMT, the increased walking and cycling, decreased car travel, it actually predicts over all the different modes, there's an increase in total number of injuries, largely due to the increase in walking and cycling. There's a slight decrease in car-to-car collisions. But there's this ratio of 1705 over 1382. That's the relative risk. That's over here. 1 minus that is the population attributable fraction, and you actually get a negative 0.23. So again, in the context of ITHIM, a negative means there's an increase in injuries or fatalities. So what we need to do to pull this all together is sum up the different pathways. So we have physical activity, that was the ischemic heart disease, the road traffic injuries, and the PM 2.5, which only, again, dealt with ischemic heart disease. So I've expressed this in terms of change in deaths per year. Again, we get from multiplying the population attributable fraction times the burden of disease, and this is the case of the road traffic injuries, you get 760, and then for dailies, you get this number. I've only put the deaths here, but you could also put the dailies as well. And you can sum up over the different pathways to get what the total net benefit or harm is. In this case, we have a lot of benefit from physical activity, some downside from road traffic injuries, and a small contribution from air pollution. In order to be able to compare regions or ethnic groups or income groups, because they have different population sizes, if you divide it by the population to which this applies, you can normalize it so you can make these comparisons between the different regions and stuff. So you'll get a chance to do that much later on in the training. So let me quickly do the monetized benefits because they're pretty straightforward. For the willingness to pay or using the value of a statistical life, you multiply the total number of deaths times the value of a statistical life. And again, it's only being done for one cause of death. What ITHIM is doing is all of the causes of death, which include the stroke and hypertensive heart disease and the cancers and the dementia and depression and diabetes. For PM 2.5, again, we multiply that fraction of the death times the value of a statistical life. And you can see again how these negative signs come in. It was minus 760 deaths, meaning there was an increase in deaths for road traffic injuries, and that's the value of a statistical life for that. Again, you'd sum these over, and I did this for all the different causes, and you get this very large number, not just for ischemic heart disease, but all the causes. You get a very large number of 64.7 billion for this particular scenario. For the cost of illness, again, I mentioned diagnostics, therapeutics, loss of productivity, which is actually the main source of monetary value. So it's the years of life lost times the median wage. When you multiply that through, that lost productivity comes out to be probably it's usually much bigger than the diagnostics and therapeutics for any particular cause. So again, this comes from the medical expenditure panel survey, where a lot of these costs are calculated. And what I'm doing here is taking the population attributable fraction times the cost burden. And what is so we have a burden of disease, but there's also a cost burden. And it's the per capita cost for that particular disease times the population. So we get a per capita cost, and that comes from national estimates, times the population to which it applies. So this can be scaled to California or a specific region. Here it's being scaled to California. So we take the population attributable fraction times the per capita cost times the population, and it comes out to be $1.62 billion per year. Again, these are all annualized costs. And you repeat that for the different pathways, and you can sum them all up. Usually the cost of illness is a far more conservative way of calculating costs. I don't have a particular preference, but I've been asked to provide this kind of information so that people can draw their own conclusions and use their own methods. So for last piece of this, before we do the exercise, is the carbon emissions, focusing on carbon emissions. So we have an emissions factor times the change in car VMT per person times the population. So the emissions factors for carbon emissions comes from MFAC, and it's weighted by VMT weighted by fuel type. So we have gas, diesel, and electric. As you can see, as we get more and more electrified auto fleet, the amount of carbon emissions per VMT is going to go down. So we have to take that into account. And the population projections into the future do take this into account. So here we have an example of the baseline car VMT per person minus the scenario. And you can see the two figures right here. The VMT weighted average of CO2 per mile traveled is 399 grams. And then when we multiply that out for the entire California population of 34 million and divide by 10 to the 12th, we express it in terms of millions of metric tons per year of CO2. And that turns out to be a decrease in 1.8 million metric tons per year. Divide that by total population, and you can re-express it in terms of millions of tons per capita per person. Whew. I know this is a tremendous amount of info to take in, but in the next 30 minutes or so, you'll be able to do these calculations as well. So let me set up the exercise, and we're going to go into breakout groups. So in your exercise, and I should point out that you should have an Excel spreadsheet that looks like this. It says example and exercise 1. The example is precisely the same example that I gave in the slides 20 and through 23. So it's just a way that you can see, here's the 100 to 200, the 50 to 150. So this is the doubling of walking, tripling of cycling. Here's the 2% VMT reduction. So all this should look very familiar, but I've laid it out in a way that you can use Excel or see what the Excel formulas are so you can do the calculations yourself. And then once you get the change in dose, you're going to have to plug it into the population attributable fraction formula. So here's the burden of disease in terms of deaths and dailies. This is your dose response function. So here's 1, here's number 2, and the change is going to come from multiplying this population attributable fraction. So again, I've worked out so that you can see how you can do this. You're only going to be doing one disease yourselves, but I put all the diseases here so that you can see what the relative risk for physical activity is, but the changes per met, as well as for some other conditions. This next piece is for PM 2.5, and then the last piece is road traffic injuries. So I've repeated the exercise, repeated the slide so that you can see how you could just manually do this. Now for the exercise, you can see that I've left whole sections blank. And that's what I want you guys to work on in your work groups. I want you to work together to do the math, do the, multiply the intensity by the time to get how many met hours per week, and don't forget to divide by 60, and fill in the yellow areas so that those are the things that are going to change, and you can come up with your own values. The cost of illness and the carbon emissions are going to be optional. If you're super fast, you can pull it off, but I'm not expecting you to do that. There'll be enough for you to work on just for this exercise on the 3 main pathways. So with that said, in your slides, 1 second, I just want to point out that oops, where's your slides? Here we go. This is going to be the scenario. It's similar. 1 second. My dog is wanting to go outside for a second. You can see the scenario is a little bit different. it's now 1.5 times, so it's not a doubling. And this is now a 4-fold increase, not a 3-fold increase. The miles have changed as well. The percent reduction is similar. So I want you to use these figures to guide you through the calculations. And again, if you need to just go back to the earlier slides to refer to what cells are going to be changed. And then if you want to plug them into the Excel spreadsheet, you'll be able to more easily do the calculations. Okay. So Meredith, do we have people assigned and do they know which groups they're in?
No. Well, two things. I wanted to know how you want the break to work. Do you want to get people in their rooms and then they all just take a break and come back to their room? Or do you want to take a break and then come back and do the rooms?
Actually, what I want to do is time the break with them going to the room. So let's set them up in the rooms and then they can start
And then everybody
working.
take a break in your room. No, I wasn't able, I don't know if, yeah, I wasn't able to do the groups ahead of time. So we have, I think you have to either do it randomly or you can do it manually based on the list that I sent, or if you want me to send those again.
No, I have the list in front of me. So
Okay.
I'm just thinking what would be fast?
I think that if you just do it, maybe even make breakout rooms manually, but then move people around, or does that take too long?
I don't know. I've never
Or we
done
can
it before.
switch, you can switch me to the host and I can try to work on it. Or people could take their break now so that we could work it all out and then.
That
either
makes
way.
a lot more sense. Why don't we
Okay.
take a break now? And I have 13 after. So, Meredith, can people hear me? Can you hear me?
Yeah, I can hear you.
Okay, great. So I'm going to go now, and congratulations, everybody. I think all the groups, I know all the groups got through the first 2 health pathways, and I think one group was still working on the road traffic injuries piece. So I think what I'm going to do, let's see here, if I can actually do this. It might be easier if I just show the key, or let's see. So if you didn't know this in, pardon me, in Excel, let's see. That you can actually unhide spreadsheets. So I'm going to unhide. And Meredith, can you tell me if you can see this?
No, we aren't seeing it.
Okay, so I may need to share my screen here. Let's see here. Okay, so can you see my screen now? Yes?
Yes.
Unmute.
Oh, okay, great. So why don't we go through this very, very quickly. And this is the exercise key, and see if your numbers pretty much match this. So let's go through this first key part where we did the physical activity, and we're working on ischemic heart disease. Everyone, I think, got this part where you multiply the METs by the time and divide by 60 to convert the dose into MET hours per week. We add this up for the baseline for bike and walk, and we add it up for the scenario for this, and we get a difference of, or actually an increase in 1.23 METs. I think everyone got that. Is there any, you can unmute yourself. Let me know if anyone got anything different than that. Yeah?
That's what we got, so.
Okay, yep, okay, great. In fact, if the reporters want to unmute themselves, that would be fine. Okay, so as we go down, we can see for the ischemic heart disease, here is part of the dose response function. That's the base value. It gets exponentiated by the square root of the dose, which is over here. And then 1 minus that is equal to the population attributable fraction. When you multiply that by the burden of disease here for the deaths or the dailies, you'll get this number. So did people pretty much get the same numbers as what you're seeing?
Yep.
Okay, congratulations, gang. Let's move on to the second pathway, which is PM 2.5. Here is the amount reduction, which is coming from this table up here. So here's the car driver is the VMT. That's how far the car is going. So that change is a 2% reduction. We multiply that 2% by this coefficient, which relates, let's see if I can hear, which relates how PM 2.5 varies with percent change in car VMT. So when you multiply the percent reduction by this coefficient, you'll get a change in PM 2.5 per cubic meter, and that's change in dose. We use that as part of the dose response function. So here is the base value of the exponent. Population attributable fraction is this reduction to this power, to this base level. 1 minus that is equal to the PAF. We multiply it by the burden of disease, and we come up with the fractions of death. So I believe that different groups may have done different endpoints. So did you guys get from your different groups, anyone get different numbers than what you see here? No? All right. For road traffic injuries, and this is the more algebraically challenging because you have to transcribe a bunch of VMTs and PMTs and keep things straight. But the important thing to know is that you go up to the top, car driver plus car passenger is equal to the PMT for the car mode. It's not a trick question, but you actually have to add them together to get the PMT. The car driver alone is the VMT. So when you array the striking vehicle, that's the car driver, and you do that for the baseline, you do that for the scenario, and then the rest is reflecting how the PMT of the different modes get the relative risk, and then you take the weighted average of that when you weight it against the number of injuries, which is over, where is, for the different modes. Here they are. There's the baseline injury. So you take the weighted average, you get the scenario injuries over the baseline injuries. 1 minus that relative risk is your PAF. You multiply that by the burden of disease here, and you get, again, a negative because the PAF was actually negative 0.17. Okay, then when you pull it all together by the different pathways, you should all come up with basically this same kind of diagram. I goofed with the basis, and the labels didn't match the formula that I had. But you should just express it. 10 to the 5th would be per 100,000, 10 to the 4th would be 10 to per 10,000. And that will be important. So you can compare different regions, race, ethnic groups, or income strata, so that you can then, because they have different sizes, you'll be able to make direct comparisons. So great. Congratulations on having done exercise 1. I think you got the idea.
So Neil?
Yep.
Hi, this is Cynthia. There's lots of questions that we have. Would it be possible that we could kind of stop a little bit before we move on?
Absolutely. So what are your questions?
Thanks, Cynthia. Thanks, Neil. I had a question about, this is, the examples that you gave of scenarios are primarily around plans. I'm wondering whether if there were a set of projects that perhaps had been funded, not yet implemented across the state, would it be possible to sum up the VMT benefits associated with those projects, like new bike or pedestrian infrastructure, and use this kind of at the state scale for an aggregated set of infrastructure projects? Or is this tool not suited to that because that would be grouping a variety of regions without the specificity of like where the VMT is reduced in each region.
Yeah, you definitely want to do it on a regional basis. If you could do it at all, it would have to be, because the burden of disease is really different regionally. And the baseline travel patterns are really different. The baseline levels of biking and walking in the Bay Area are radically different than what they are in the San Joaquin Valley. The level of motor vehicle injuries, the rate is so much higher in the central. You definitely need to regionalize it. The challenge of how you could construct scenarios using projects is that you're going to have to somehow predict what the overall average is, how it shifts that distribution of walking and biking. And that's actually going to be a off-model, complicated procedure. So I'll get into later into what the model does and what it doesn't. But this aspect of scenario construction is actually off-model. You'd have to come up with a mechanism knowing what the efficacy of these different kinds of projects are in shifting population level travel patterns, and then through population weighting, come up with what the average shift would be for a region. And that's no simple feat. So, but we can talk about that in maybe offline or more in detail, because I know there's a state need to do things like that. But the model itself can't directly help you. Once you figure those travel patterns out, then it's a simple matter that the model can quantify the health benefits. But before that stage, the model itself doesn't help. Go ahead.
Neil, couldn't we, if Layla had all the projects and she could figure out that from those projects there's a overall ratio of a doubling in walking and a quadrupling of biking, for example, and she can see that from her projects, or that's the expectation from those projects, then she could plug that ratio for the entire state. And although every region is different, she could end up with a statewide improvement, knowing, but very clearly giving the assumptions that she's using.
Yep, that could be done. The problem is the question of reach. So even though you have those projects, you have to predict not just the people who are in the catchment area of the projects, but the entire population. So you're going to have to get a sense of, again, it's not just the people who are taking advantage of those projects, but it's also people who are not taking advantage of the projects. Otherwise, you'll be way overestimating the benefit. Again, this is something we could delve into more deeply offline, or have a follow-up.
Another question that came up was, I think there may be a misunderstanding that in order to run this model, we have to do these exercises. And I explained to the group that the online ITHIM, you don't have to do any of this. This is behind the scenes. So it's just to understand what the model is going on. And I don't know if you wanted to clarify that.
Yeah, again, my goal is to make this not a black box. That's the big criticism that public health people have of transportation modelers, is that it's not very clear how they're doing their calculations and what is the conceptual basis. So I presented these simple exercises to give you a flavor for what the calculations look like behind the scenes and what the methodological basis is. So no, you don't have to do these exercises. The idea is that when you do see the results, you'll have a much better appreciation for those three things: that there was a burden of disease, that there was a dose response function, and there was a change of dose. And that's what's predicting the change in health outcomes. I think without the exercises, it's harder to well, at least I think it's harder to make it concrete, like what's really going on. So this repetition of those three components, I think, is an important part of just feeling comfortable that you can explain to someone else So if you have to take this to your manager and say, well, how does this thing work? And you have no idea, and it's just a black box, then I think the credibility will suffer. So that's what these exercises are all about. It's really to empower you to be able to explain it to other people, to feel like you know enough about it to be credible spokesperson for the results.
And then there was one last one, which is, could you explain the rate of 10,000? A lot of folks are not epidemiologists, and so.
Yeah. There's actually no magic to this. The reason why it's 10,000 is to re-express it on a population basis so that you don't have so many decimals to look at. Because when you divide the deaths by 34 million or 35 million people, you get a rate that is 0.0000, you know, there's so many zeros that visually you don't know what you're looking at. So by multiplying it by a constant, whether it's 10,000 or 100,000, that makes it easy to see what the rates are. You know, now that we have, unfortunately, COVID among us, we do the same thing. We express those case rates per 100,000. Because again, if we just divided the entire population by the number of cases, we'd start off with saying what's the case rate? It's 0.0000, you know, there's so many zeros that visually people can't understand it. So when you go to a system of multiplying it through by a different basis, it just makes it visually easier to explain what it is. And there's no magic to the 10,000 or the 100,000. It's just a matter of convention. So, okay. Let me move quickly because we have one more exercise to do, and I think we can pull it off in the next 30 minutes or so. So I'm just going to move on and just talk about the model insights. One is that the physical activity pathway generates more health benefits than the PM 2.5 pathway, but that is sort of baked into the model, given the coefficients that we currently have for dust response. The higher the level of active transport, the more health benefits, the multiples of a baseline. So groups or geographies with the highest baseline benefit more than those with the lowest. So if you have a multiple where you already have a region like the Bay Area that could be easily, you know, 30, 40 minutes a week, and you multiply that by 4, well, that benefit's going to be a lot greater than a region where the baseline level is only 5 minutes a week, because when you multiply that by 4, you only get 20 minutes. So it's also just sort of baked into how, you know, the arithmetic or the mathematics of the model. On the other hand, with fixed time, or the Surgeon General, which is a specific instance of fixed time, where it's basically 75 minutes a week of biking and 75 minutes a week of walking, it works the opposite direction. Those who had the lowest baseline are actually covering more physical activity, and they're getting more benefit because they started at a lower level, but they're all coming up to the same high level. So again, that's just baked into the model. And it has implications for regional equity and things like that. Because multiplying things by baselines actually edifies the existing inequities, where if we actually all have the same goal, the benefits get distributed so that the groups that started off lower will benefit more. Okay, safety there's often this case, especially with the baseline multiples, is that you know, safety in numbers, even though there is a square root function that diminishes the risk of injuries with increased mode share, it isn't entirely compensated for bicycling and walking modes, where in fact you often see this increase in absolute numbers of injuries to bicyclists and pedestrians. It doesn't have to be that way, but safety in numbers is not the only mitigating factor. Infrastructure and other things, policies can also deflect it even further. The other insights is that we see that the current generation of SESs are not generating much health benefit or carbon reduction. And that's sort of part of the problem of these constrained, economically constrained plans that don't really move the needle in a dramatic way on the level of physical activity. So that's just another thing that we see. Now, the strengths of the model are, it's credible, it's definitive in the sense that deaths and years of life lost are things that people can relate to. The evidence basis, these dose response functions have been essentially vetted through meta-analyses and the World Health Organization. And so there's really a filtering of the best epidemiologic evidence that underscores these dose response relationships. The comparative risk assessment model has been widely established in public health. It's nothing new or novel. So from that standpoint, it doesn't impose any new burdens on users to believe something that's really different or abstract. And as I pointed out before, the use of disability adjusted life years puts mortality and morbidity into the equation. Whereas if we only focus on deaths, we're going to be missing a large part of what is driving healthcare costs and morbidity in the society, especially those middle-age groups that are contributing a lot of dailies but don't die until several decades later. Okay. Again, there's a lot of strengths of the model. The log normal distribution is pretty much what we see for physical activity. Safety in numbers is pretty much what we see. We have the ability to project into the future, which is really helpful for planning, because the NPOs are doing that as well. The platform that we're going to see shortly is free and open source, so that's nice, and that there is extensive documentation. Some of the assumptions need to be talked about. One is that we're projecting both the burden of disease and the change in the burden of disease at some future time. So the ramp up period is not something we're actually seeing. We're acting as if the implementation of the scenario magically occurred in the year in which we're doing the analysis. And we know that's not true. We know that it takes years to get these big capital projects up and running. And so the time horizon and how we're measuring the benefit doesn't actually include the ramp up period. So this is sort of the optimal level that we're getting when things are in steady state, assuming everything gets implemented at the time horizon. I think these other things I think I've covered in one way or the other. Oh yeah, for the physical activity, there's a handful of causes, which include, let's see, colon cancer, breast cancer, depression, and dementia. They actually rely on dose response relationships that include not just travel related physical activity, but leisure travel as well. So for those causes, there's an assumption that when active travel goes up, there isn't a concomitant decrease in leisure physical activity. Since most of the population is at that low part of the curve, so there's not a whole lot of physical activity they can substitute for because they're not doing much to begin with. So I don't think that's a serious assumption that deflates the results. And of course, it's okay to have scenarios in which there's just less travel. The scenarios have been designed so that the built-in scenarios have been designed to make the assumption that they are actually for carbon reduction purposes. You can have increased physical activity through walking and cycling without any substitution of car miles. But that's not a carbon mitigation strategy. That's something else. So we are really focused on that part of it. So that is an assumption that in these built-in scenarios, there is a concomitant decrease in car travel with increase in active modes. And that is a pretty big assumption. Okay, now I just wanted to quickly mention what the model doesn't do, because that's really important. That gets into the issues that Layla, I believe, was raising about scenario development on one side and the calculation of health benefits or harms on the other side. So where You can see there's a line between these two areas. Really, all the issues around scenario development are off model. So they could come from project policy or some other kinds of scenario that are goal-based, which is pretty much what we have for the state goals. They're aspirational. They don't have any modeling behind them of how we got, those numbers. But there are ways using travel demand models in which you can use a quantitative methods and due to transportation investments, different infrastructure, actually change the travel behaviors. So it could be distance to transit and how many more stations you have and where you're expanding your light rail or your bus lines and things like that. So travel demand models incorporate those features to give a sense of how people's travel patterns are happening. There's also land use models and other things that are also capable of showing how population travel patterns change with the Ds. So again, this is somewhat a famous formulation in land use where you have distance of transit, destination accessibility, diversity of land use, density and design, block length, interconnectivity of the roadway network, all those things. They all are there to produce a central metric for ITHIM. That's the distance traveled per person per day for the given mode, whether it's walking, bike, motorcycle, bus, truck, the works, cars. If you can generate that metric from your scenario modeling or reading of the literature to see what the effect measure might be from a protected bike lane or any number of other infrastructure projects or policy, you can use that as input to ITHIM. But the derivation of that metric is something that is not part of ITHIM. So that it's a really important distinction to make of how scenarios are developed versus once you develop those scenarios and know how the average travel pattern alters, you can then use that as input to ITHIM. Okay, limitations to the model is really important to get to. Geographic scale and aggregation. It's really about the data. Once you go below a county level, you really can't break down the age and gender walking and bicycling patterns. Especially for the older age groups, you have a lot of missing data. So that's a big problem. And there are workarounds, but that's it. The other thing is there's a lot of heterogeneity in air pollution within a particular geography. There's hotspots, there's all kinds of differences around busy roadways. Because ITHIM is looking at airsheds, they're very large areas, and it's missing this heterogeneity. So it's not to say that there could be high pollution hotspots, but they would get, in essence, homogenized in the approach that ITHIM, this aggregate version of ITHIM. There are versions of ITHIM in a research mode that simulates individuals. And in that kind of research model, you can take a person and move them geographically through their journey to work and to school and to recreation and all those things. And each time they're dwelling in a particular location, you can find out what their air pollution levels are if you model that. And that kind of heterogeneity is captured in this individual level ITHIM. But at the aggregate level, where we're aggregating over age and gender and ethnic groups and all this, we miss out on that heterogeneity. So we just realized that this model is really good for direction and magnitude. But anything that's really related to project level activities is really not a good fit. There would have to be an awful lot of assumptions to make it feel valid for very small geographies. Okay, so in the remaining half an hour, I'd like to give a whirlwind tour of the website. So you'll all be able to put this into your browser. So why don't you boot up, go ahead, and I think we have enough bandwidth that everyone will be able to have the model up and running on their machine. So go ahead and do that. Go ahead and click on it. I'm going to actually be running locally, but that's okay. You should all be able to do that. So we need to get a sense from folks whether if there's anyone, let's put it this way, if anyone is having difficulties getting the model up and running through this URL, send Meredith a note, and then Meredith will break in and let me know, okay?
I'm gonna try to also copy that because I don't think people can click on they can click on their own slides, but
yeah.
Let me put it in the chat.
There you go, thank you.
Oh.
Yeah, and if you're trying to run it off a smartphone, it's not gonna work. You need to be on a laptop or a tablet. Well, I don't know if tablets work either. I don't think they'll work. But, so if you have a desktop, this should work out just fine. Okay, so I'm gonna quickly go through this and then we're gonna have another exercise. Okay, again, the organization of the website, as I mentioned in the introduction, it starts in a sense from left to right, going from problem orientation, the framing around climate change and health, and it gives you instructions on how to use the model, and then this heart, which we're going to dwell on, is run ITHIM. And then after you get some results, you want to say, well, how do I take this to action? You know, what are the best practices? What are some of the projects that Layla was talking about that might be moving the needle? Those are the kind of things that we need to really move on. I mean, the model is great and fine, but it's really the action that to mitigate carbon, which is the urgent call to duty for all of us. And then there's the user support section that allows people to learn more about the model and how to use the model and things like that. So why don't we go to the ITHIM, and I'm going to boot this up and get this thing running. So when you come in, you should all have the splash page here, the landing page. Hopefully that's the case. The about goes through a series of introductory explanations, explains a little bit about the model, gives some instructions, describes the scenarios in a little bit of detail, gives the geographies. We're going to cover this when we actually get to the model, time periods, and the methods. So the method section actually goes on for quite a long scroll. It all has bibliographic information, so if you want to get real detailed about it, you can get it off the website. It's also in the user's manual. So let's come to that. You should all be there. So you should all have this, and there's a little bit of an introduction. Health impacts of travel scenarios in California regions and counties. Okay, and then everything below the ITHIM tool is really now part of this interactive web environment. On the left panel, this is where you make your selections. And on the right side, that's where you get your results. By default, the output format that you should be seeing is the report. Okay, so everyone should have their screen look something like what I have up on my screen. So I'm going to go through this very quickly because I won't have time for the exercises, because I think you'll get probably a lot out of the exercise just by hunting and pecking and looking for where the outputs are. So you have to make a number of selections. You have the options for selecting the scenario, and I'm going to go back to the default, which is going to be the CARB. That's the default. So when you enter, you'll actually see the screen that looks more like this. So you get the listing of all the built-in scenarios, including at the very bottom is a user upload. And again, if you run a travel demand model, or you've done some kind of work like Layla was suggesting of coming up with this average change, there's a particular format for putting the data in, and I will briefly mention it, but it's documented in the user manual how to do that. Okay. So again, these are a pick list. Every time you pick a different scenario, you can see that immediately the summary report, the data change. So if you pick a different geographic area for the same scenario, you'll still get, in this case, California Strategic Management Plan, but now it's the Sacramento area. So all these things are tailored so that pretty much instantaneously you change a scenario, a geography, and a time period, the results will automatically change to reflect that. So that's not much magic to this kind of, making it super duper easy for people to run the model. Now, there are several different outputs. You have the report, and this has been labeled like the elevator pitch. So if you want to just print this out and bring it to your management and say, well, what does this scenario do? Well, you have a little elevator pitch, bullet point, just a handful of bullet points. And they talk about the change in the travel patterns. Then it talks about the total number of deaths, often broken down by the different modes. Then you have monetized health benefits. And then you have what the carbon reductions might be. So all of these things are sort of this logic of describing travel patterns, health impacts, monetized value, carbon reductions, repeat for all the different formats, whether they're the report, the tables, or the graphs. I'm going to now go to another popular format, which is an infographic. Again, our users wanted to see something that appeals to more of a sort of a public, people who aren't super technical, but it gives a little bit of background. And you can see there, what it's doing is it's juxtaposing the scenario that you picked with two other scenarios that are sort of fixed, the optimum carbon reduction and optimum health reduction. So, or benefit. So the US Surgeon General is sort of the upper limit of health benefits and the low carbon driving. So you can always compare the plan you picked with these other two options. So you can see in this case, the Caltrans has less carbon reductions than the Surgeon General, and a lot less, which is exactly what you expect out of a low carbon driving. Nonetheless, it is making an improvement as far as years of life. Again, you can look at this in a very colorful way to get an idea of what the impacts are. The real heart of this is really tables. And there's different tables that reflect different levels of detail. There is a summary level, and that's the default when you hit tables. There's a medium level and a high level. What the differences are, again, they're all trying to start out with describing travel patterns. Now, this first table is an overall summary of everything: travel, health outcomes, cost, and carbon emissions. But then there's a little bit more refinement here as far as travel, distances, you get times and distances, you get the health benefits broken down by pathway, and then you get the monetization of that using both cost of illness, and then you get carbon reductions. So what the increasing level of detail does by clicking on medium provides, again, starting off with travel times, you get a breakdown by age, a little bit by gender, and then you get all the different modes, and then you get a profile by different diagnostic entities, and it goes on to get the health benefits. You get up to the high level, these are tables that are seriously for the most detailed oriented analyst, where you get breakdown by travel times, by age and gender. It breaks it down by baseline scenario. You get the burden of disease broken down by diagnostic entities. But then you can pick specific diagnostic entities that you'd like to look at. So here is the default is ischemic heart disease. But if you wanted a different one, let's say you wanted to look at stroke, you'd be able to choose that as well. So here's the stroke one that we just picked. It also allows you to do it by pathway: physical activity, PM 2.5, and road traffic injuries always comes out the same. So you can have graphs as well. Takes a second. There we go. So you have graphs, and all these things are pretty much, you can just click on it, save the image as, and then cut and paste it into various documents. what's nice about the tables, because it's in HTML5, when you get a table, you can actually highlight the table and cut and paste it into Excel. Do that. And you get your table with all the formatting. So that's one of the advantages of this. You can also download the tables as well as a CSV file, as I mentioned previously. Okay, so we have about 20 minutes to do this. So what I want you to do is move to the exercise, because I think you're going to get much more out of it by doing the exercise than going through this. So here we go. And this is something we can do all together, and it's going to be a free-for-all. So Meredith, can we unmute everybody?
I think everyone can unmute themselves, but yeah, I think that is a good idea to do it together so that we're not taking time.
Okay. So what I'd like you to do is, this is the selection. So this would be CARB 2030 scenario for all of California and the year. So this is, again, scenario, geography, year. And then what is the annual health benefit in deaths avoided? This is a cue to what table. So the summary table number 1 is where you'll find the answer. So who wants to volunteer the answer?
It's 5,777.
Okay, so here's tables. So let me go over here, California, and scoping plan. And let's do tables. Okay, the net benefit as, was that Fang? Is that
Yes.
you? Yep.
Yes.
So it should say 5,777.
Mhm.
Is that what people got? Okay, I'm going to move on to these slides because I can actually change the one second, folks. My machine is cycling because I'm trying to get to where I can reveal the okay, 1 second. Just hold on a second, folks. Okay, let's see. Here we go. All right. Oops. There we go. Okay. What is the baseline per capita median minutes per week for bicyclists? Now, this is something I didn't cover yet, but I wanted to highlight. You can change the units. By default, it's mean. And this is for active travel time, because remember that distribution is log normal. So if you wanted to get the median, you have to click on median, and it will automatically change for the parts of the tables that are dealing with time for active travel. Okay, so I think I've revealed what the answer is. But the question is, what is the baseline level? Anybody want to just call it out? Yeah, I don't hear anything. You there?
1.7.
There you go. I'm struggling with the box. Okay, so let's go to the next one. What is the annual per capita miles traveled in the baseline / scenario for, again, the CARB 2030 California selection? Anybody want to blurt it out? Annual per capita miles traveled.
Is it 11,627?
That's it. You got it. Very good. All right, let's keep on going. Whoa, I don't want to reveal all the answers here. Okay. Unfortunately, I have construction next to me, and the house next to me is undergoing construction. So if you hear a little buzzing, that's what that's about. Okay, what about the next one? What does the negative sign mean for the PAF, deaths and dailies for road traffic injuries? So you're going to see that in summary table number 4. It's these negative signs. What do they mean? Anyone want to blurt it out? Should be pretty easy.
I know people in our original group, we went over this.
So
Somebody
increase in deaths and
There
valleys.
you go. Thank you. Very good. All right, let's move on now to what is the monetized value? Again, it's for the same CARB scenario. What is the monetized value of health benefits based on the value of a statistical life in billions of dollars, really billions per year? Anybody want to blurt it out?
56.6 billion.
There you go. Great. Okay. Let's having a hard time here with the. There we go. Okay. What is the net annual aggregate car carbon reduction in millions of metric tons per year from the baseline for that same scenario?
$94.6.
That's the baseline level, but the reduction is the subtraction of 94.6 minus 77. Okay, so we're looking at what the difference is. That's the reduction. So if you do the math, it'll come out to be 17.6 million metric tons per year, which is not trivial. Okay, what is the car VMT reduction in this scenario? So you're gonna have to do a little bit of math. Okay, it's in the medium table. So now you're gonna have to go to tables and then pick medium, because this will give the breakdown by car driver. So again, baseline minus scenario over baseline, expressing that as a percent is what the reduction is going to be. Okay, anybody got that number yet? I assume that you'll be able to make the calculation. According to my calculation, it's an 18.6% reduction in car VMT. So I don't know, Cynthia, if you guys have thought about it in quite this way, or try to quantitate what the VMT reduction implied in the scoping plan scenario is, but it's actually a pretty substantial reduction. Okay. Next question. What is the population of California in 2010 using this ITHIM model? So you have to go to high table resolution number 1 table. And again, you need to know where to find this, because when you re-express the results for 10,000 or 100,000, you need to know what the total population is. So anybody want to know where that is? It's right at the bottom here. 34.5 million, 2010. Okay, next pieces. Okay, don't worry, Chispa. The next question is really about modifying a table to express the harms and benefits on a population basis. So what we want to do is take the CARB scenario 2010. So that is the table that we saw before. That was just this table. Go back to the summary. Okay. And we do it by pathway, right? So it's this table, but only parts of the table. We're only looking at deaths and dailies without these population attributable fractions. So we're just looking at the count and the value. So we want to re-express those on a population basis. Okay. Are people with me? To see how that would be done, you need to know what the total population is. That's why we need to know that the high table number 1 is where you will find the population. Of course, we keep doing this for California, but if you had chosen a different geography or a race ethnic group, you're going to get a different number there. Okay. So let me just reveal this. And this is what you should be able to do. Okay, let's keep on going. And here are a few more questions. And I think we'll have time. We have 10 minutes. I think we should be able to do this.
Neil?
Yep.
This is Cynthia. So the one that you just did before, wouldn't that be an option for Layla, in that you could calculate, if you know, doubling and tripling of the project, and you can do it if it's all on the South Coast, you could run the numbers and then just get a fraction based on the population and then multiply it by the population of the project?
In theory, that could work, yes. But again, you'd have to define the project reach area. And then it would be a weighted average of people who participated in the project versus people who didn't participate in the project, come up with the overall population average. So
Yeah.
how you would do that.
Okay.
So I would point out that this is what, in essence, the MPOs do when they do large project analyses. They run the model for the entire, region. And the overall average reflects people who were both in the project area and outside of the project area. But they come up with an overall average. But it's based on, they're running their travel demand models, which are very detailed. But that's in essence how it is done. Yep. Okay, so let's see, this is going to be a little bit more challenging. So now we're going to pick different scenarios altogether. So everyone go to, you want to do baseline multiples. So we're going to do a different scenario. Let's pick Southern California and let's do just walk and bike without changing transit. Just let it be. Just by you. Okay, my dog's probably hungry at this stage. So let's pick baseline multiples. I'm going to pick Southern California. Where is it? It's underneath here. There it is, Southern California. Go into here and pick 2 and 3. Now, if we want to get tabular output because we want to be able to answer the question. Okay. So the question is, what has greater net deaths benefit if you double walking and triple cycling, or if you triple walking or double cycling? Okay, so these are situations in which you're going to go back and reverse it. You're going to compare this with triple here and double here. And you're going to get results that will change automatically. So you'll want you to compare that. Which one has more health benefit? Someone blurt it out.
Triple walking.
There you go. Yeah. Walking has more benefit. And that in part is because the population levels of walking is so much greater than cycling. And the baseline level for cycling is so low that even if you triple it, you're not going to get anything near the level, even though it's more energetically intensive, it won't compensate. So anyway, yes. All right, so now let's ask a variant of this. You probably saw there is a box here that says % of car miles substituted. And what that's all about is the recognition that maybe you won't be able to do that one-to-one mile substitution. For every car, for every walk and bike mile, you decrease car miles. Let's say you can only do half of that. That would mean there would be a 50% reduction. So the numbers will change based on that. So I want to ask you a question. What happens as you go from 100% substitution down to 0? Does the net death benefit get larger or smaller with 0 miles substituted? Okay, anybody have a guess? for the sake of time, I'll just point out that here we are at 100. Here's the triple walking, double cycling. At 100%, we have 1,447 deaths avoided. I'll bring it down to 10%. You can see that number now is decreased. There's less benefit there. If I bring it down to just 1% or 0, it's going to be even less. Do you think you have an idea of why this is happening? Anybody want to blurt out why you think we're not getting, or what of the pathways might be reacting to the fact that we have more car miles?
PM 2.5.
No, actually,
Oh, injury.
Yep, that's what's going on. With more car miles, you're getting more PMT and VMT. It's going to lead to greater cyclist and pedestrian deaths. And you'd actually see that in the high table number 5. Okay, I should just point out that this idea is essentially what's been happening nationally. We've had in recent years an uptick in the number of cyclists and pedestrian deaths, and part of that is that there's been an increase in mode share with the popularity of bicycling and cycling, but there hasn't been a concomitant decrease in miles traveled to the point where pedestrian bicyclists aren't at risk. It also probably underscores some of the difficulties that the Vision Zero projects are having actually getting down, both in New York and San Francisco. I'm less familiar with what's going on in LA, and this is all pre-COVID. The difficulties they're having trying to get down to 0 levels, in part because of this increase in mode share due to cycling and walking. Okay, let's see, we have one more, which I think I'll give as homework because it's a little bit complicated, because I want to leave at least a few minutes if there's any more questions. But this is now saying, let's compare 2 different regions. So we have, on the same scenario, we have the Bay Area and we have the Surgeon General. We have the San Joaquin Valley, the same time period. So what I'd like you to do is fill out this table expressing the benefit or harm for each of the pathways in dailies per 10,000 population, and ask the question, which region has a greater per capita change in their burden of disease? What role does RTIs play in each region? Okay, so you have to construct a table that looks something like this. And should I just go ahead and show the result, or do you want to go home and do it? Meredith, any preference?
Yeah, I feel like since we're almost done, you might as well show the results so we can finish, and maybe if anyone has questions.
Okay. So again, this is just iterating the model, but using these values come from the table number 1 of the high level of, let's go to the Bay Area, okay, 7.1, I think that's the one I used. So this 7.15 million is coming from right over here in table 1 at the high level of resolution. The rest of the data are coming from table summary number 4. So it's really interesting to see how these regions are quite different. You can see because the populations are different. The Bay Area is almost twice the population as the San Joaquin Valley. You can see that for the physical activity benefit, even though there's nominally they're same levels, the rate is radically different. It's far higher in the in the San Joaquin Valley. And again, this reflects the low starting point, because the Surgeon General is an example of a fixed time. So when you go back and look at how many minutes per week of active travel, it's far lower in the San Joaquin Valley. That's why it's getting a higher rate here. Look at what's going on with road traffic injuries. It is tremendously different. you see that the rate is almost 10 times greater in a negative sense, that there's far more injuries going on in the valley due to this scenario. That's because the underlying injury rates started off being a lot higher due to road traffic injuries in the San Joaquin Valley. So anyway, you can see what the net benefit is, but it really, you need to look at each of the different pathways to see that it's quite heterogeneous. The physical activity benefit is far greater in the San Joaquin Valley than it is in the Bay Area, but it's, in a way, it's sort of canceled out in some degree by the large increase in road traffic injuries. So these are some of the insights that you get from using the model. And it's a real heads up for policymakers about implementing different strategies given the baseline conditions. Okay, equity analyses, I just want to point out, are done really the same way. We haven't quite integrated the race and ethnicity as part of the drop-down menus yet, but we're working on it. So in the meantime, you'll have to download the different versions from the website. So when you get to the website and the user support, you get to this part of the website, you'll see a part that allows you to download right here where it says income, race, ethnicity, and income. You'd be able to download versions of the ITHIM. They're each in a different folder, and you just run the model by clicking on the R program that initiates it. You have to also install R and some of the packages, so it's a bigger commitment. That's why we want to get it up on the web and integrated. But the way you do the analysis is basically the same as you saw for the regional analyses, where you break it down, you get the raw tables, then you have to divide by the population, and then you can do the comparisons. And that's pretty much it. Again, the user support materials, you're invited to do the web tutorials, the video clips, the user's manual goes into great detail on methods and how to use the website. So I'll leave it up to folks to do that. If you want to get into the code itself, you can download the code. It's free. Just acknowledge where you got it from, and you can modify it and do whatever you'd like with it, really. And I think that's really it. The credits go to a whole team of folks from UC Davis, from the Air Resources Board, the Department of Public Health. And so it's not just my effort, but it was a lot of folks who really helped do this. Okay, so I know I sort of overdid my welcome by a few minutes, but if there are some burning questions, I'll definitely stay on board. I understand if you have to go, you have to go. But if you'd like to stick around, I'll be available for at least a couple of minutes now and be able to answer questions. And you can always email me. I respond pretty quickly to people's questions about the model. And if you have any difficulties using it, you can contact me and I'll see if I can help you with navigating the website.
Thank you for that, Neil. And thank you everyone for participating. And yeah, we'll stay on for a few minutes. And if there are any questions, but I just wanted to say thanks in case people have to get off, and thanks to Neil.
So do we have any questions?
Yeah, maybe not.
People are exhausted.
I always have questions, but I'm going to defer to other people first.
Hi, yeah, this is me. I just have a quick question. I remember I talked with Cynthia about this many months ago, but just want to make sure I'm remembering correctly. So if we go back to the website and we have the baseline and the scenario, so if we pick a different year, like 2020, say, so in this case, if we pick like a 2020 for the year, then the baseline in this case is saying that it means the 2020 population, but with the 2010 activity level. Is that correct?
No, you're going to, let's see. I'm not sure why. 1 second, I'm going to, let me see if I open it in a browser. not going to see a change in the baseline level of travel patterns. So with the built-in scenarios, if you have a scenario in which, let's say you have a travel demand model, it's actually predicting what the travel patterns are going to be in 2040 or 2020, whatever year, it would, through the user upload, take that data and put it in for both baseline and scenario. So it's often called business as usual rather than baseline when you project it into the future. But if you don't have a model to tell you what that is, what the built-in scenarios are doing is just taking the baseline 2010 level and keeping it that way. So, you know, here's a 2020. I mean, you're not going to see any difference in these levels. It's all determined by what scenario you've chosen. What's going on behind the scenes is that it is altering the burden of disease and the population. So let's take a look at that high table in 2020. You can see now the California population now is at 41 million. Previously, it was at 34 million. So you can see all these age, gender cells have changed. Okay, and the same thing with the burden of disease. They are now reflecting increased population by age and gender, but also that additional modeling of how the disease rates are going to change between now and 2050. So chronic disease rates are going to go down slightly by age and gender. So what you're doing is altering the burden of disease to make it temporarily correct for the time period that you've chosen. But it will not alter any of the built-in scenarios as far as the travel patterns.
I see. Okay.
Yep.
Thank you.
That's again off model. That would require modeling what the travel patterns are going to look like over time, over the next couple of decades. And without a travel demand model or some other kind of modeling, it's going to be difficult to come up with valid estimates for what that might be. Nonetheless, all the large MPOs do this. They have land use models, they have other kinds of models that help them. So you might want to consult with the MPOs to see what their estimates of baseline travel is through outputs of their travel demand models. And again, different MPOs are have different levels of comfort sharing that with the public or with other agencies. So you'll have to, like MTC puts it on their website. They make it very accessible, but some of the other MPOs don't share that so readily.
Thank you.
There's another question in the chat from Victoria. I don't know. I don't want to put you on the spot, Victoria, if you don't want to turn on your microphone, but you could do that or we could read it.
I feel like Meredith, you're such a good interpreter of my questions. Sometimes I don't even make sense to myself. But Neil, I was wondering if there's any potential way to do add-on scenarios that could help to modify injury and the injury related outcomes. So I'm thinking about Vision Zero and our strategic highway safety plan that have targets for reducing injury, and then and then I'm thinking, different kind of comprehensive policies that look at this, embedding comprehensive traffic safety education or complete streets policies. Is there a way that ITHIM could have an add-on scenario to a scenario to affect projected injury outcome? Injury outcomes?
Yep. I'll have to go back to that one slide back here about what the model does and what it doesn't do.
Okay, so and I apologize if I missed out earlier, but I just...
Yeah, because it's really right here where that rubber meets the road, because you're talking about coming up with effect measures for different policies or investments that ultimately have to get translated into how travel patterns will be different. Now, there are mechanisms within ITHIM, this idea of the dose response, the safety in numbers. 1 second. Oh, my dog is about to chew through the cord. 1 second. Right now, there's a square root function that defines that dose response relationship between mode share and injury risk. Part of the quote unquote add-on is helping identify what additional deflection from a square root would be through safety improvements. So we could, if you think there's going to be a change in policy or investments that actually will further deflect, there is a parameter list that users can change in the desktop version, especially make it really easy, so that instead of that square root, you can have another X% improvement in safety. We did this for autonomous vehicles, where we predicted what the changes were going to be due to safety, because it's been stated that, with all the different interventions, sensors that will, and vehicle-to-vehicle communication, vehicle-to-infrastructure communication, that the rate of injuries in the cars of the future are going to drastically be reduced. So we reflected that in the coefficients in ITHIM on how to do that. So the answer is yes, but the bigger challenge is going to be, if you think through vision zero, how much of an effect do you think that's going to have? That has to come from modeling or some effect measure, whether it's how intersections are designed or how speed limits are, reduced, how that, what effect that has on, travel patterns. That's a huge undertaking.
Well, that's good. Yeah. Would you? That's interesting. Yeah, I think that, we look at these issues simultaneously. So while this is so exciting to see, again, always the projections of disease burden that's reduced in certain areas, it's like, our branch within the department is always focused on injuries. And so, when we are working closely with Caltrans on its strategic highway safety plan, and there was the Zero Traffic Fatalities Task Force that recently came out with their recommendations for affecting safety through some new modifications to speed management setting practices, and also the exploration of use of different technologies for speed enforcement. Yeah, so I actually just wanted to see if maybe this was something that was already on your radar, or and if it was something that we were interested in pursuing. Would we need to talk to you further about that, Meredith, about that? How,
Yeah, I'd be more than thrilled to participate in discussions about how to modify the model to reflect those kinds of changes. The work of doing a literature review, which is probably another piece of this, there's the crash modification database, which is referenced in the decision support materials, which will give some guidance on what the effect measures for different. Then it'll be a matter of reach, how widely disseminated. So these are all assumptions, and then again, it's going to have to be population weighted to come up with what the average changes might be. So I'd be willing to participate in that, but I'm not willing to do the literature review because it's a huge undertaking. Just like Susan Handy's group did and UC Davis in general has been the group that's helped with quantifying, through land use, what the elasticities are, what's the likelihood of change in in CARB, largely focused on CARB VMT. They really didn't spend much time on how bicycle, on the non-motorized modes, which was really what we need as well. But if we could have all that put together and synthesized, I think it's just another application of ITHIM. And as I mentioned before, we've already done this on, I've helped Seth in one of the prime modelers in Fresno COG, Seth Scott, around how to do this for some of the work that he was doing. We've done this for autonomous vehicles. It's come up repeatedly over the years about how to alter the model to be better able to reflect safety conditions, both for the striking vehicle and for the victim vehicle.
Right.
So we can work on that. I'd be more than glad to help out.
Cool. Thank you so much, Neil. This is great. So yeah, wonderful presentation. I really appreciate it.
I would just add, just on that same note, I work on AB 285 implementation, which is involving trying to help the Caltrans CTP, be the California Transportation Plan, be a bit more constrained by, objectives that will help us meet our climate goals. And it seems like a first mile, last mile solution of, figuring out people who are able to do that first mile or last mile actively and demonstrating what that looks like on the model could hit both co-benefits of folks, getting that 40 minutes in. I mean, I'd love to walk 40 minutes a day on my commute if it made sense. Actually, in San Francisco, where I live, that wouldn't be a problem, but I'm now based in Sacramento. I don't know that that's the same where I could afford to live in Sacramento. And so I think that, but I mean, even from where I live to the central business district in San Francisco, I cross 2 freeways. There are inclines, and there's fast moving traffic, as you can imagine. And so I think that and I'm very new to this, so I'm not sure how all of the modeling works. And I was struggling in my breakout group, I told everyone, but it would just be nice to see a model that said that, the 40 minutes is a, a first mile, last mile to your job. And that can be done on a scooter, or it can be done biking, or it can be done walking. And I know that seems very complex, and I don't.
Yeah, I hear you loud and clear, because I think you're bringing up some really good points. But I would also point out that the average car commute right now is taking up, what is it? According to the American Community Survey, I think it's something like 280 minutes a week of time. So if you could substitute walking and biking where it makes sense. Right now, there's a lot of places where it doesn't make sense. There isn't an infrastructure. It's not safe. The land use won't necessarily support it for all kinds of reasons. But on the other hand, a lot of where the future population is going to be living hasn't been built yet in California. So there's opportunities there. And this has been the argument all along, is that as new growth and infill presents itself, we can direct our land use to make it more possible so that people can bike and walk in 20-minute communities. So it's 20 minutes out and 20 minutes back. There's your 40 minutes. But it's going to be a huge leap in order to do that. And quite honestly, the way that SB 375 was structured did not provide enough incentive to really make a big difference so far. So we're talking about really dramatic changes. And we haven't talked about post-COVID California, but there will be opportunities to rebuild, and how we rebuild will have a huge impact on the future health of California. Because if we build back with infrastructure that supports biking and walking, those are long-term investments that will keep paying off year after year after year. As Linda or Meredith mentioned at the very beginning, if people are just sitting, in congested highways in their electric vehicles, it's not going to really support economic productivity unless they to work from inside their stalled vehicles on highways. I mean, it just is insane lifestyle to perpetuate. So there are policy decisions and value judgments and huge investments. It also gets into whether we're going to invest in public assets like transit, or we're going to let private individuals swap out their cars and make it basically a private investment. Although it's never truly a private investment, because there'll be charging stations and other things that will get government subsidies because of the equity issues and the cost of vehicles. There's already concerns that certain groups are not going to be able to afford electric vehicles. So there's lots of issues with the electrification, which we do need, because we are not going to bike and walk for really long distance travel. So we either have to do that with rail or personal passenger vehicles will have to be electrified.
Thank you.
Thanks everyone for hanging on
Yeah.
a little longer. That's been a great discussion. I don't mean to cut it off, but I want to give everyone a chance to get going. So any last things?
I had a question on the multiples. I always have problems with this one, Neil. I was wondering if you could just quickly go over the website.
Sure. So
Let me go. So the baseline multiples, when I put the increase of walk, it stops at 5. If I, you know, go as high up to 10 for bikes and 4 for transit.
Yeah.
Could you explain?
Yeah.
I can't remember why that happens.
There's limits. Because the substitution is happening on local roads and arterials. It is possible, I mean, only mathematically, to go negative. I mean, you have so much substitution that there's a limited amount of car arterials and car local roads, so that if you have exceedingly high levels of active transport and you're subtracting out car miles, well, there's only so many car miles on local roads you can subtract out. If the increase is so huge by biking and walking, you go negative, and that doesn't make any sense. So that's why I put limits on the maximum amount of multiples of walking and biking, so you don't wind up with this illogical situation of you've basically run out of local roads and arterials to do your substitution on.
Okay, thanks, that helps. But you did, I mean, why 5? Could it have been 6 walking, and then bike could be, instead of 10, could have been 8? Or
yeah, I just had to make a decision about what I thought was reasonable. So, you know, if we wanted to have a sort of a different combination of those things, you know, we could talk about, you know, altering the model a little bit to do that.
what was this based on literature, or just
No, just to give people a large enough range to be meaningful, you know, but not nothing so excessive that it would generate every time people used it, they would wind up saying, why is this going negative? Why is this failing? It's just a reality of there's only a limited number of car miles.
Right. No, that makes sense.
That you could actually overdo it. And I mean, I suppose I could have held it at 0 and just kept on 0, 0, 0, but that seemed to be misleading. Okay, that's a very sophisticated and subtle question, but yes. Okay, I think I don't hear any more questions. I just want to thank everyone for hanging in with me and being here. You've been a really great group. This is the first time I've ever done it on Zoom. So your breakout groups, just thank you so much for your high level of participation and engagement. So just thanks. It was rewarding for me too.
Thanks everyone, and thanks Neil.
Thank you, Leah.
Um,
Thank you, everyone.
Take care, everyone, and
Thank
yeah,
you.
let us know if you have more questions.
Thank you.
Bye-bye.
Okay, bye, everybody.
Bye.